Okay, I think we'll get started for today. Apologies for the slightly slow start. So I'll start with a brief introduction. Hi, my name is Katie Patterson. I am the Knowledge Management Lead at the Global Platform for Action on Sustainable Energy and Displacement Settings. The GPA is a platform driving collaboration across the humanitarian development and private sectors to scale energy access solutions, including clean cooking and electricity access for displaced and host communities. And then we also support the transitioning of the humanitarian response to more sustainable energy solutions. The GPA was established in 2018. Our mandate comes from our steering group of humanitarian and development partners, and our coordination unit, of which I am a part, is hosted at UNITAR, and we execute that mandate across 5 working areas: data and research, training, high-level advocacy, coordination, and innovative finance. Before we kick off today, a few quick things. So firstly, just so everyone, in case anyone hasn't noted, the session is being recorded today, so everyone's aware. We'll also start off with a quick audience poll just to understand our audience a little better. Mariana, if you could share the poll. If everyone could take a minute to answer what type of organization you're working with and whether you are currently working on a healthcare electrification project in humanitarian settings. We'll just give that a second. And also, while we're waiting, I will just remind everyone too. So we'll have a Q&A session or segment during or after the presentations. And if you could share questions in the chat, that would be great. And then if you have questions as well and would like to open your mic, we do have that option during the Q&A. I see a few answers are still coming in. Okay, I think we have the breakdown. Nice to see that a lot of people are working on healthcare electrification in humanitarian settings. I hope you will find this session really insightful today. So to kick off, I'll say that understanding how to ensure sustainable long-term access to electricity for healthcare and humanitarian settings has been a growing focus of the GPA's research working area over the past 2 years, and especially in the last 6 months. Today, the WHO estimates that globally around 1 billion people seek care from facilities that have unreliable electricity access or none at all. And this is particularly acute in sub-Saharan Africa, where only 28% of healthcare facilities have reliable electricity supply, and even more so in fragile and displacement settings. So in our research, we really wanted to understand the barriers to not only getting these facilities electrified with clean energy, but also ensuring that power supply remains reliable over the long term. And we wanted to understand how different partners in the sector could work together to better incorporate humanitarian settings into broader healthcare and energy planning. So we launched our first report on this topic, the briefing on healthcare electrification in humanitarian settings, in February at the Energizing Healthcare Conference in Nairobi, which was hosted by Sustainable Energy for All and the WHO hosted Healthcare and Energy Platform of Action. At that conference, we also had a session where we had a really great discussion with a lot of different people about the topic. And so before we dive into the report presentation today and the broader agenda, which you can see here, I want to invite Marilena Lazapoulou, who will share a bit about, who will give us opening remarks and share a bit about the outcomes and the discussion that we had at that conference and sort of how this work links to broader healthcare electrification efforts. And so Marilena is a senior energy specialist with SE for All's Powering Healthcare team, and she brings over 12 years of various engineering, implementation, and advisory experience within the energy access sector, and we are very glad to have you here today. So Marilena, please take over.
Thanks, Katie. And good morning, everyone. It's great to be here. So as Katie said, we held the Energizing Healthcare Conference back in February. And as you can all understand, that was just when we all started understanding that development aid and also the stakeholder landscape is rapidly changing. So as if for all, we understand that we need to react on these global changes. So we need to be more innovative. We need to establish new collaborations, and also we need to look at new business models to attract new investments. And that's not only in humanitarian settings, but also on the global landscape. So some key highlights from this roundtable on humanitarian energy that we co-hosted with GPA and HEPA is first of all that short-term funding cycles remain one of the main barriers to powering healthcare in displacement settings, but also the structure of this funding, given that PV has high upfront costs, and this is not in line with the usual humanitarian aid. We had a long discussion on carbon credits. So we heard from A2EI, who has a carbon trading platform. They're piloting to see if verified credits in humanitarian settings can actually get a higher price than other credits. On the same subject on carbon trading, we had invited a biogas company in Uganda, which we also support financially through our innovation fund, that has moved refugees completely from firewood to clean gas, generating carbon revenue, and then using these profits to reinvest in community expansion. So we literally saw the potential of biogas as solar backup to displace diesel. Again, not only in humanitarian settings, which this is there's a huge opportunity, but also outside those settings. There's a lot of conversation also around clean cooking and the nexus with electrification. We heard about some integrated approaches that were tested in Tanzania. And we see this nexus as really innovative for the sector that could attract new climate investment as well. Of course, there's a lot of discussion on training, especially as the importance of training host community technicians for O&M by including them in the O&M scheme. It was nice to hear UNHCR also announcing their targets to 50% of healthcare facilities running into diesel will be solarized in the future. Also, UNHCR discussed about how they shift their approach towards supporting local NGOs and the private sector, which is increasing the trust among refugees and host communities, and was very welcome from the audience. And last but not least, we always talk about coordination. We all understand the importance of it. So there's a huge need to coordinate amongst humanitarian organizations. And when they find ways to work together, they can also essentially save on costs. But eventually, we should definitely integrate energy access into national healthcare and energy planning if we do want to close the humanitarian healthcare electrification. So with that said, I'll pass it back to you, Katie. Looking forward to the rest of the speakers.
Thank you so much. And yeah, we look forward to continuing trying to build partnerships and collaboration in this space. So now I will take a few minutes and try to share a bit about this report that we worked on and what we found during our research process. So essentially, to give some background, our team spent 6 months gathering case studies from 11 different country contexts. 4 of these were implemented by humanitarian partners, 3 by development actors, and then another 4 of the cases are actually investment cases that approach healthcare electrification from a more holistic country and regional level using innovative business and financing models. Most cases are drawn from sub-Saharan Africa, which is the focus of the report, but we also drew on Selco Foundation's rich experience in India. And the goal of including different case study types in the report was really to understand, on one hand, the current approach being used by humanitarian partners to electrify the facilities that they operate, and that's something that I'll talk about in depth now. But we also wanted to understand what these partners could learn by observing or working with actors in the development space or plugging into broader energy access initiatives. We also wanted to better understand how humanitarian healthcare facilities do or don't currently fit into national healthcare electrification planning and into large-scale healthcare electrification programs like HEPA and SE for All's Powering Healthcare. So for each case study, we aimed to collect and present in-depth insights for potential project developers on how the project was designed, partners involved, and the energy needs assessment that was conducted, and especially what approaches are being explored to ensure that systems installed remain operable over the long term. You can see on the screen an example of our case study from Somalia and the type of information that we gathered. We also worked with NORCAP energy experts on assignment across 13 countries to collect data on the electrification status of existing health facilities in humanitarian settings, with the aim of both building out a pipeline of facilities that are currently in need of solarization or refurbishment of existing systems, and also to better understand the characteristics and demand profiles, what actually is a humanitarian healthcare facility, which is the term we use in the report. And my colleague Shahab Javeri at the end of our webinar today, who leads our healthcare electrification work, he'll speak briefly about how we are continuing to build on this pipeline and the next steps in our research. So now I'll talk about what we've learned in our research about humanitarian context specifically, and then we'll hear in our case study presentations about how these settings relate to other healthcare electrification work. And what we found is that in most cases, health facilities serving humanitarian settings are small. They have around 13 beds on average and potential electricity demand of between 10 kilowatt hours and 36 kilowatt hours. And most of this is used for lighting and some basic medical equipment. Essentially, they're similar in size and features to an off-grid rural health clinic in many ways, because oftentimes these facilities, like the displaced communities that they serve are located in remote areas. And they're powered by standalone systems, either diesel generators or solar or other renewable energy systems or hybrid systems. And they often fall outside of the purview of national health and energy authorities in a country. And instead, electricity supply for these facilities is often initially developed by UN agencies and INGOs, providing the humanitarian response in these contexts. And these organizations, as they've begun to work on decarbonizing their own operations, there's been a positive push for solarization of humanitarian health facilities. So UNICEF, for example, has set a target to solarize 10,000 health facilities globally. And as Marilena mentioned, UNHCR is targeting solarization of 50% of its facilities that it operates by the end of 2025. However, this situation, the way that these facilities are currently administered means that they are also affected by the short-term energy emergency mandates of humanitarian organizations, which usually run on 1 or 2 year budget cycles. And this makes it challenging to finance investments in solar and other renewable energy sources on the one hand, since higher spending on energy from operational budgets reduces the money available for providing other life-saving humanitarian activities. And this means outside fundraising is often required to solarize these facilities in the first place. And then the short-term nature of humanitarian operational structures also restricts financial and operational planning for long-term operations and maintenance of these systems once they're installed. In many contexts, these health facilities and their energy supply are handed over to national health authorities eventually, but these partners in some cases can lack the know-how or resources to maintain the system over the long term. And to try and overcome this challenge, humanitarian partners have begun employing several strategies to try and address it, such as incorporating multi-year O&M periods into the contract with the EPC company installing the system, and then combining that with capacity building and support to prepare local technicians to maintain the systems. Across both the humanitarian and development cases analyzed in the report, we see that investing in building the capacity of community technicians, EPC companies, and health facility staff to maintain the systems is crucial, but committing the necessary funding for 20 years of maintenance, including supply of spare parts, is still a really tricky part of the puzzle to solve. And in some cases, humanitarian partners have begun to trial more market-based approaches to healthcare electrification, with the aim of enhancing long-term sustainability. And this is especially true in contexts where mini grids can be deployed, and where there are opportunities to leverage income-generating end uses. And to draw an example from one of our case studies, Alianza Shear's mini grid project in the Dolo Auto Complex in Ethiopia, powers 16 community services today, including health facilities, using a model in which CapEx costs are covered by grants, and then O&M is managed by a local cooperative, and costs are covered by an affordable tariff charge to end users, including members of the displaced and host communities there. And I won't go too in depth on the learnings from all of the case study categories, since our guest speaker today will be doing so, I think, in a much more engaging way. And then instead, I just want to quickly highlight some of the overall findings that we took away in our research about how to close the healthcare electrification gap in humanitarian settings. Essentially, we found that stronger and more frequent partnerships are key to closing this gap, especially, I think, as everyone knows, in the current environment. And as we'll see in our case studies, despite the small size of the health facilities in question, to electrify them and ensure that those systems remain operable over the long term requires collaboration between a lot of different stakeholders, humanitarian agencies, governments, health authorities, energy authorities, and also, of course, public partner or private partners and community members. And working together makes it possible to leverage the complementary expertise of different partners, but it also requires to build a lasting coalition, essentially, identifying appropriate incentives to keep everyone engaged. And so for private sector partners and investors, this means finding solutions that are commercially viable. For governments, it can mean building projects that further their national and local development goals. For donors and humanitarian organizations, it's often about cost saving and opportunities to reduce or avoid emissions. And for communities, most of all, it's about providing affordable, higher quality healthcare enabled by an energy supply that remains reliable over the long term. And once these partnerships are built, stakeholders then, of course, have to work together to address key barriers to the long-term electrification of humanitarian healthcare facilities. And in our research, we identified 6 areas for collaboration, including these facilities in national and regional electrification planning, as well as larger healthcare electrification platforms is key, because this is what makes it possible for humanitarian settings, which are often just a handful of facilities in the broader context of a country's healthcare facilities in need of electrification. It allows these facilities to contribute to the scale of these initiatives, and contribute to larger development goals around healthcare and energy. Partners can also work together to mobilize funding and technical resources that humanitarian and government partners may not have access to on their own. And they can also collaborate to identify innovative business models for covering not only upfront cost barriers, but also long-term system maintenance. And then importantly, making sure that those innovative business models work for displaced communities. Incorporation of digitally enabled data collection and improved data sharing between partners is key, as remote monitoring can not only reduce costs of O&M in particular, but also enable monetization of environmental and social benefits of electrifying humanitarian healthcare facilities. And this unlocks new funding sources. That's where things like carbon finance and renewable energy certificates come in. It's also important when designing systems to do so with the aim of enabling delivery of healthcare services. And I think we'll talk more about that in our Kenya case study. And then lastly, it's essential to build, lastly but not least, it is essential to build the capacity of local partners because this helps to maximize the benefits of these projects for communities, as well as ensure their long-term sustainability through local ownership and engagement. And we'll see this and talk about it more for sure in our Sierra Leone presentation. And so I have talked enough. And now we will move on to our first case study presenter. And so we'll dive deeper. So each of our cases today, presentations today, align with one of the categories of case studies included in the report. And first, we'll take a closer look at how UNHCR as a humanitarian organization is working to achieve its target of electrifying 50% of health facilities it operates by 2025. And so we'll hear from Fabrice Igor Chente, Energy and Environment Officer at UNHCR, who led an effort to refurbish and strengthen the long-term O&M of 4 health facilities in Mbera refugee camp in Mauritania. So without further ado, Igor, please take the microphone. Okay. Maybe, not sure. It looks like Igor is not, yeah, I think that his connection has dropped. So in that case, we will skip ahead a little bit. And Paul, if you are able to take the mic, I will.
Hello,
Hi, let
Sonia.
me jump through and then we'll see if Igor can rejoin later. Perhaps he's having some technical difficulties. So I'll give a quick second introduction. So we'll skip to our second case study, which is one of our development organization-led case studies in Sierra Leone, focused on building local capacity with the aim of enhancing sustainability and scalability of healthcare electrification in fragile contexts. And so for that, I will introduce Paul Yilia, Manager and COO of the Energy Nexus Network. He is a development consultant with expertise on cross-cutting issues and technical implementation of development programs, including at the Water and Energy and Health Nexus. So Paul, please go ahead.
Thanks, Kathy. It's a pleasure to be here. Thank you so much for the great work you guys are doing. And thanks for inviting us to share our learnings from Sierra Leone. We're happy also that our case study is captured in this document. And we really hope that this type of discussions can put a spotlight on what local actors are doing, because the very essence of the reason why we had to create such an environment in Sierra Leone is to deal with most of the issues that you already mentioned. So, I mean, when I listen to your presentation and I hear Marilina also from SC for All, there's really nothing hidden. If really we are serious and we want to push healthcare electrification, we know exactly what to do. So why is it not happening? And I will share my case study, but I also have some thoughts as an academic. Towards the end, I think I want to make some suggestions. But we really think that anchoring healthcare electrification within local capacity is key. We will show with these examples that we have done. Just to give you a project overview, Sierra Leone, please check on Google. It's a very small country in West Africa. It should not be difficult to find. What we did was to deal with small systems, small healthcare facilities. For those of you who are familiar with the health value chain, primary healthcare facilities, graduate into primary hospitals, secondary hospitals, and tertiary and teaching hospitals. We have a similar system here. We call our primary healthcare facilities PHUs, or peripheral health units. So these are small systems. So it's very simple to light them up with 1.1 kilowatt systems, or 3.4 kilowatt for the CHCs, the community health centers. But most of them, with a 1 kilowatt system, you can light up the facility because it's just one building with 3 or 4 rooms, and then you can also do the accommodation for healthcare workers. So we did 18 of them, targeting almost 180,000 people, because the catchment area for these healthcare facilities is somewhere between 4,000 to 5,000 people. So you could see already, because these are last mile and the first point of contact for the population, they have an impact. So with some grants, we were able to deal with this philanthropic grant. We were able to address healthcare situations in these 18 facilities as a proof of concept. Now, how did we get to know the healthcare situation? I happened to consult for SE for All, so these slides are actually taken from the market assessment and roadmap, powering social infrastructure in Sierra Leone, the document on health. So you could see the statistics for electrification in the country is very poor. So you have 26% access. If you break that down, rural population access is less than 5%, and that is where most of the healthcare facilities, especially the primary healthcare facilities, are located. Urban access can go up to 55%, but again, it depends on whose statistics you are dealing with, but electricity is heavily unreliable. So the numbers keep changing of the total healthcare facilities, but up to 80 to 90% of them have unreliable access. 38% are completely in darkness. So this is serious, right? So with these statistics, we saw the need to intervene. And we started making approaches to partners in India through a Selco Foundation and through the Global SDG 7 Hubs initiative. We were able to deal with some funding. We were able to use some funding from mostly philanthropy to power these facilities. Go on, please, if you can move to the next slide. So key here is the key stakeholders. So I would say a little bit about the Energy Nexus Network. It was founded in 2019. It's a regional knowledge and facilitation hub created to deal with the ecosystem challenges. If you can go to the next slide. These challenges need resilience because there are several elements in the ecosystem. The next slide, can you have a quick view of those ecosystem elements? Technology, of course, you could see innovation, policy in government, incubation of small businesses that are getting attracted to have an opportunity in the market, to implement, to deploy technology, but also capacity building needs that Kathy mentioned. Finance, of course, is a huge one, but usually most of the attention is on finance and technology. But these other elements create the processes, the enabling processes that lead to success. And for us, we have as a mission to build these elements of the ecosystem and to make sure that in all the projects that we implement, we understand all of the elements and how they play, including, of course, the backward linkages, where the technology comes from, because we don't manufacture them here in Sierra Leone. And then, of course, the forward linkages to understand the terrain, the roads, the network, how to deliver the technology in those last mile communities. Next slide, please. So we have 4 programs. 2 are important for this discussion. One is the Health Innovation Program, where we use energy as an entry point to strengthen healthcare systems. And then our Business Incubation Program, where we incubate small businesses. These are usually vendors of solar systems, but also energy procurement and construction companies that deploy the solutions for us. We are seeing the needs to incubate them, to train them. So when the capacity to train is not in Sierra Leone, we send them to our partners abroad to get further training, or we link up with our partners from here to strengthen their capacity So they become actually training of trainers for the last mile facilities where we deploy solutions, because we usually also talk about local technicians in those communities. Kati? Next slide. So our health innovation program, of course, tries to strengthen healthcare systems, but we want to do it in a holistic approach. So we integrate climate sensitive technologies, like looking at both adaptation and mitigation, but also improving the quality of healthcare services for the patients, as well as the healthcare workers that most often reside in those healthcare facilities. So we kind of really look at it as a nexus approach between health, a nexus between health, climate, energy, and also livelihood. Actually, one of our programs is dedicated to livelihood, improving the financial well-being of people in the communities where we work. Next slide, please. So for the Health Innovation Program, we have decided to focus on the least in the healthcare value chain. If you look at the illustration on my right, or on the right, you will see MCHPs. These are maternal and child health posts. We have also CHPs and CHCs, the community health centers. These are the primary healthcare facilities. And the reason why we focus mostly on the MCHPs, they are usually located in last mile areas. They are usually the first point of contact for anybody seeking Medicare at a healthcare facility. And then, of course, they cater for the needs of those communities as for basic illnesses, most common illnesses in the country. And if you strengthen them, then you take off the burden for the next layer in the value chain. And also you are dealing with most of the population, because Sierra Leone has 60% of its population being rural. And our estimation is that for the 650 MCHPs, if you really strengthen them, you are dealing with close to 80% of the population in rural areas. Next slide. So the key stakeholders was us, the Energy Nexus Network, providing that anchor as a local partner, helping with design and implementation, but also monitoring activities and engagement with the Ministry of Health, which is important also, especially for scaling in future. And then, of course, maintaining our strong links with the global hubs, the global SDG 7 hubs, as the primary technical partner, supporting us with the incubation program, but also building local capacity within our organization. Next slide. So for project design, the key guiding issues that I want to discuss is mobilizing funding. I think this is very key. I think I don't want to overemphasize that. But usually what we see is that development finance comes also with a lot of conditions. So it's also very difficult for local partners to compete successfully. And so you'll see that even in Sierra Leone, current scaling of healthcare electrification led by SE for All is predominantly anchored with international entities that are deploying solutions. This has serious consequences for long-term sustainability. I think I will not go into that, but later maybe I'll mention that as a recommendation. But also important is stakeholder identification and engagement processes. We follow a multi-tier approach. I saw also with the SE for All deployment, it's a similar kind of approach where you start with the central government, and then the central government refers you to the district health management team headed by the district medical officer, and then that entity then identifies healthcare facilities and recommends you to meet the facility management committees in the villages, and then you engage the local leaders in those villages, because this is also very important for sustainability and acceptance and later on transfer of assets, because these health facilities usually start as community initiatives before they are handed over to the government. So it's also very important to include them in those conversations. And then, of course, during the energy needs assessment, capacity is needed to do the correct assessment, do the right designs, procure the services of vendors and EPCs. It's also very important to include the private sector in this, because for long-term sustainability, you want warranty on the product. You also want to sign a contract for O&M checks and services. And so this is very key to have the private sector involved, and also to build that private sector itself, so you don't disrupt the market. We have seen also in most programs, big programs, the local private sector is not involved. They bring international actors to bring the products, and then once they deploy, they do some training, but they are gone, and the backward linkages, there are disconnection with the backward linkages, and sometimes these problems, these systems are very difficult to keep and maintain.
We need to conclude quickly. We're running a little bit behind on time.
Yes, one last slide. So for lessons learned, the key guiding issues here will be identifying and assembling the right kind of coalition. And then, of course, during program design and implementation, it's a reiterative process. So you have to go back and forth between the key actors, including the private sector, the government, and then the facility management committee. And then, of course, to overcome risk, it's very important to have O&M checks and services included in the contract with the EPCs. But there is the issue also of running CapEx, and usually projects don't take care of that. And when you pass on the facilities to the government, it's also difficult for them to secure funding to run that. But again, you highlighted that in your introductory remark, Kati. Overcoming barriers, I think funding is going to be an issue, especially that running CapEx I mentioned for existing projects, but also because of the large scale of projects of facilities that need electrification. I think a consolidated effort is needed, not to waste current resources that are coming into the country, but also to build systems within the Ministry of Health to anchor project development and maintaining projects that are already ongoing. I think I'll stop here, Kati. Thank you.
Okay, great. Then we're going to jump back in our slide deck a little bit, and then I will hand over, and thank you so much, Paul. And I'll hand over to Igor, who will talk us through his work with UNHCR Mauritania. So Igor, are you on the call?
Yes, it's okay. It's okay.
Okay, perfect.
Sorry.
It's all yours.
Thank you, Catherine. So, thank you, Paul. Also, it was interesting to hear about your case. For Mauritania, I think it's a very simple case. Just to give you the short overview of the context. In Mauritania, now you have around 260,000 refugees, mainly from Mali, in the camp and also out of the camp. The law, we have also almost in all African countries, the low rural electrification, less than 5% also in Mauritania. So this low electrification rate has a lot of negative impact on the provision of healthcare service, both in the camp and also out the camp. So when we did the assessment, we found out that we need something like around 64 kilowatt peak of grid solar system to power the healthcare facility inside the camp. And also the cost of the project is 180,000 US dollar. So just to show you how it's difficult to secure fund for this type of project, it took us around 2 years to have this fund. Next slide, please. So let's talk about the project design and implementation. So how we did the identification, how we identified the need. So the need was identified by NORCAP and also UNHCR. We conducted the energy audit inside the camp and stakeholder consultation. And we found out that they use almost 80% of healthcare facilities in Mauritania in the camp and also of the camp are using diesel generator, which is very bad. And also the need the need is very huge. So I remember when we discussed with people in the camp, they say that when they really need energy to go to the next level, because they have a lot of, it's difficult for them to give the quality care because they don't have energy to keep medicine, to keep vaccine, and also they want to move to telemedicine and they don't have energy for that. So we set the project goal. So the project goal was to install the new solar system because the old one was very bad, and also upgrade the existing systems. and establish the functional long-term O&M operation and maintenance system. Next slide, Cathy, please. Okay, so let's talk about the key stakeholders. So the first one is UNHCR, because they fund the project, even if it was difficult for them, because it's the operation fund, so they use it to fund it, and also NORCAP to technical design and also oversight of project. The Ministry of Health here is one of the key stakeholder, because after a lot of discussion with them, we found out that even if the UNHCR leave the operation, even if the UNHCR leave the country, the only institution that will stay in Mauritania is the Ministry of Health. So we discussed with them and we set something like a contract for we will install the solar system and they will do the operation and maintenance. This is what we decided, and they was willing to do that. So we also work with a lot of local company in the camp and also out the camp and also in the whole country. So they decided to help us to size the project, to find to find the equipment, because Mauritania is it's not a small country like Sierra Leone, but it's a very small country based on the population, and it's a very close country. So also the World Bank, because the World Bank is through the project INAIA funding the Ministry of Health, so they are part also of the project. Next slide, please. Okay, so the need assessment the need assessment approach was in 3 phases. So the phase 1 was analyze the macro data and pre-assessment activities. So analyze the generator operation data, cost assessment of energy need, identification of the key stakeholders. And then the phase 2 was the data analysis and reporting, data analysis, development of technical solution, simulation of solution, and preparation of technical specification. And the last phase was the validation of result and technical proposal by the Ministry of Health, because we always have to go with them on this type of project, and also to secure funding, what we did with the UNHCR and the World Bank. So the funding implementation strategy. So the challenge that because when we finalize the design of project, we share the proposal to the lot of partner. We are looking for fund, but it was very difficult because they are not, the type of fund that we have now in the humanitarian is not exactly what we need, because it's short-term fund, and we need something like long-term fund for O&M support. So the solution was to discuss with the Ministry of Health, as I said before, and they decided to include the O&M in the fund, in their operation, in their normal fund, the O&M fund. So that means when at the end of the year, they say that in Mauritania, for this post-care, for this post or maybe for this camp, for this healthcare in the camp, we will give them X amount of fund just for O&M for the solar system. So this is what we did, and it's very interesting, because now we are confident that even if we are not in Mauritania, even if we don't have funds, the solar system will still working. So next slide. Okay, community engagement and training. So yes, this picture is the type of the system that they used to install in the camp. So they used to install the very bad system. They used gas battery. It was very difficult to explain to them that this is not how solar system works. So there's a lot of lack. There's lack of skills in the energy in Mauritania, unfortunately. So we are trying to train people. We are trying to train health staff. We are trying to train also ministry, because they don't really understand. Now it's a bit okay, but it's difficult. It was difficult for them to understand that we need fund to do O&M. We need fund after the installation of solar system. We need also fund to do the operation and maintenance. So that was very difficult at the beginning, but now, because they show them the importance of operation and maintenance, we show them also the importance of do the good sizing and to to use the good material when you want to install the solar system. So now UNICEF, we are managing the project. We have also one local partner on the ground who is working with us, and it's working. And for the moment, everything is working well. We have the budget. We are securing the budget for the maintenance for the future for like something like 2 and 3 years, and we will see in the future how it's going to be. Next slide. Okay, so to talk about the risk. Okay, the first risk is the high future replacement cost in case of problem. The weak local capacity, what I mentioned before. This is also very difficult to address because there is not a lot of like technical school in Mauritania. There is a lot of good technician, but we are working on it with also ILO and the government also. So the mitigation is training the technical capacity of stakeholders, local partner, private company, government. We are working with them. Training and forming partnership with local entreprise. We are trying to have something like a strong partnership with the local company, and long-term also partnership, and seeking a long-term funding for operation and maintenance. Also, this type of fund, we are working on it. It's very also difficult, but the government, they understand the need, but we also need to work with other humanitarian agency, other funding partner, European Union, and everybody to explain. We have to explain to them that it's very important for us to secure long-term funding for operation and maintenance after installation of solar system. We just don't need to give them the capex for installation, but we also need to work on the other part. And also the idea we set also something like an agreement with the health facilities that the fuel after the installation of the new solar system, the fuel saving from the generator they will use partly for operation and maintenance, and the other part we use for refugee healthcare. Next slide. Okay, so talking about lesson learned, we found out that the operation and maintenance are essential for sustainability of solar energy. This is crucial part. And also the coalition of stakeholder and local capacity building have been. So for the future, the integration of the solarization of healthcare infrastructure in the national strategy and secure large-scale funding. Yes, this is also what we are working with the government. We are working with the government. They are open. The good thing in Mauritania is that government, they are very open. They are open. So because they understand that they are working with some experts, so they understand very well the context. They understand that we have to keep infrastructure working for the long term. And yes, so they also have the fund. They also have fund from the World Bank, and also the World Bank, they understand the importance of this type of project. So this is why we are trying to secure the long term. And also we are also trying to do something like advocacy with others, partner like European Union. We are working with them also on this type of project. Next, thank you.
Okay, sorry, you don't have any more slides, are you?
Yes, it's okay. Thank you.
Okay, sorry, I thought you said next. But thank you so much for that presentation, Igor. And now I will jump quickly into introducing our last speaker so that we still have some time for Q&A. And also just a reminder to everyone, please put your questions in the chat. And our speakers should also feel free to answer questions in the chat as well, if they can. So for our last case study, we'll hear from Yannis Holzegel. Yannis is a renewable energy consultant at UNICEF who has worked on an innovative investment case for solarizing health facilities in Turkana County in Kenya, which hosts Kakuma and Kalubeyi refugee settlements. The project piloted a new system sizing tool or employed a new system sizing tool developed by UNICEF, and also explores how energy as a service models can be employed to ensure long-term O&M of health facilities, electrification systems in fragile settings. So Yannis, please go ahead.
Yeah, thank you so much, Katie, for the introduction. Just to note briefly that I do have a bit of a cold, so I hope that's not going to disturb us, but also it means that I will probably be keeping this short and sweet, so it's to our benefit. Just to briefly speak about how this project came about. The main reason was that across various projects in the region in Sub-Saharan Africa, as well as in Kenya, we had observed that even though systems are being installed in facilities, oftentimes that installation is not very long-lasting or sustainable. And so part of the reason for developing this investment case was really to try and identify a more sustainable approach to healthcare electrification. Then the second aspect was that at the same time as coming up with this idea for the investment case, we had also developed a renewable energy sizing tool that is called SunSavvy, that I will also present in a second in a bit more detail. And again, we then utilized the investment case to basically refine this sizing tool. The next slide. Yeah, so maybe just to briefly speak about the sizing tool that we have developed. It's accessible on the website sunsavvy360.org. Initially, it was developed mainly because we noticed that within UNICEF, especially within field offices and country offices, there weren't many technical staff available that have experience with renewable energy that could actually carry out surveys for solar systems. And so what we did was to develop a sizing tool that can be utilized by basically anyone with or without technical knowledge, that accurately sizes solar systems for health and education facilities, as well as for solar water pumps and then for buildings. So the tool works in such a way that you have a mobile-based offline survey tool that you basically use your phone to answer questions and fill in the survey. And then once this is done, you submit this tool, and then you then get sent an Excel sheet to your email, with which you can size the system. And so all the inputs from the survey are automatically populated into the Excel sheet, and the Excel sheet also automatically sizes a solar system for the facility. Again, this is available at the moment on the website. At the moment, the online version is only web-based purely, so it doesn't have the mobile app function, but you can do the same basically as you would on the mobile phone. You can do it through the browser. Next slide. Yeah, so again, on the investment case itself, how we did this was to, first of all, identify the most suitable region in Kenya, which is Turkana County. That is particularly because of the relative vulnerability to climate events, and then also, of course, it being a UNICEF project, vulnerability of children, especially in Turkana County, which is in the northwest of the country. And this is also the county where you have most of the displacement settings. We then carried out surveys using the renewable energy sizing tool at 11 representative health and education facilities within the county. And we extrapolated data from these surveys to the county level to then identify what would be the need at the county level if we were to electrify all facilities. We also carried out some stakeholder interviews with private sector companies in Kenya, just to be sure how they usually deploy these types of projects, and then how we could then potentially adjust this. Yeah, next slide, please. So some of the findings, I think the first one, not necessarily too important, but we would need around 19 million USD to electrify some close to 300 health facilities and close to 600 education facilities in Turkana County. What I found much more interesting is that when we did visit the facilities, first of all, what we saw basically confirmed our suspicions that we had before, which is that many facilities really have solar systems already installed that are not working. There can be a number of solar systems installed at the facility, either for different purposes. So for example, if you have a health facility, there can be one solar system for the lab, one for the maternity ward, depending on what the donor has funded. And then there can be extra solar systems installed because, again, the first ones are not working. And then even the ones that are installed, most of the systems really have issues with operations and maintenance. In most instances, there is basically no O&M plan, and there is also no budget for O&M. In one facility in particular, it was really quite shocking because their system hadn't been working for, I think, more than a month, and all they really had to do was to press the reset button on the inverter. And that just shows that basically when this system was installed, most likely there was no adequate training done, or even if training was done, then this was either not well received or the person that was trained had left the facility. But there are really basic issues that make systems not to work in the long term. And so I think this is something that we do have to keep in mind while we think about solarizing facilities. It's not just about solarizing the facility and then ticking it off, but making sure that this system that is installed is actually working for a longer period of time. Next slide. So one of the ideas that we had developed, and I know that now it's a bit more mainstream, but at the time, so the investment case was developed in 2023. This was still relatively new concept, was this idea of an energy service model to help with ensuring longevity or sustainability of the system. So again, the idea here is that when you first install the system, the energy service company, or ESCO, co-finances and installs the system together with the donor. And then on an ongoing basis, the energy service company is being paid for delivering the service of providing electricity. And what this means is that, for example, if you have a 5-year or 10-year contract with this ESCO company, you basically pay them on a monthly basis or quarterly basis only if and when electricity is actually provided in a sufficient manner to the facility. And this, again, is supposed to then incentivize the ESCO to operate and maintain the system well, and for it to actually be long-lasting. So this is a different approach to what I used to call the install and forget approach, where we install and then forget about the system. It is better to have a more sustainable approach like this that can, of course, also be adjusted, that ensures longevity of the system. Next slide. So, of course, since coming up with this type of model, ESCO model, a couple of things that we have realized is that, first of all, if the private sector were to enter into any contract directly with the public sector to roll out this type of model, most private sector entities would rather be hesitant to do so because of their experience in working with the public sector and how public sector sometimes fails to make payments. And therefore, I think that there are some entities at the moment that are working on developing guarantee mechanisms that will basically guarantee these types of contracts and will give assurance to the private sector that the public sector will indeed pay. And then if they don't pay, the guarantee provider would step in. Second option is to utilize renewable energy certificates, which provide basically payments for every megawatt hour generated in a solar system to cover some of the O&M costs. So these renewable energy certificates are not available in every country, but for example, in Kenya, they're available. And there are different options there. The DRECs and PRECs are some options. I know that there are also other ones. DRECs stands for Distributed Renewable Energy Credits, and then PREC stands for Peace Renewable Energy Credits. Yeah, I think this is as much as I wanted to say, and happy to hear your questions and answer those afterwards. Thank you.
Right. Thank you so much, Yanis. So we have one question in the chat already. Please feel free to put more questions in the chat, or if anyone in the audience would like to raise their hand and ask a question to one of the presenters directly, you're welcome to do that. The first question that we have is someone noted that when energy systems are introduced to facilities and displacement settings in general, oftentimes you have a lot of informal and evolving energy demand as people purchase new appliances and bring them in that maybe weren't anticipated in the initial system design. And so the question is, how are such evolving and informal energy demands taken into account in the planning and sizing of healthcare electrification systems in displacement settings? And are there approaches in place to manage or guide changing usage behaviors post-electrification? So if anyone would like to speak to that, maybe Yanis.
Yeah, thank you, Katie. So for the first aspect, I will just give the very practical example of what we did with the Sun-Savvy renewable energy sizing tool. So what we did was to initially only look at the appliances that are within the facility already. But of course, as was noted and as mentioned, that when the facility is electrified, likely there will be additional appliances that will be connected. There are a few different options to going about this. First option is to look at basically the national energy levels of national, let's say, standard levels for types of appliances that you do have in different tiers of health facilities. So, for example, in Kenya, again, there are different tiers of health facilities, starting from dispensaries, health centers, to regional hospitals, then to national hospitals. And each of these types of facilities have specific appliances that should be available within the facility. So again, the sizing can be done based on those appliances. And then also the Sun-Savvy tool, what it does is it sizes the system for the worst month of the year, so the month in the year where you have the most rain, and then adds basically 20% on top of that, so that even within the worst month you have 20% excess electricity. That is just to make sure that exactly these types of additions are being catered for. And then there's also an additional option to increase by another, I think, 25% in the tool, in case you want to, oversize your system. But we also have to, of course, be aware that oversizing initially will lead to higher costs, and therefore you can, implement less systems. And so systems should be installed in a modular fashion, such that when you do notice that there is an increase in demand, you can basically just add on some PV or batteries to then meet that demand. Thank you.
Igor, please go ahead.
No, it's perfect. Just want to add that also, this is also part of discussion with the different stakeholders. When you discuss with the management of the One Health centers, for instance, you can ask him, what do you plan to have in the future if you have energy? And also, technically, you have something that we call expansion factor that you can add when you do the sizing. So there is different way to do that. But the key part is to really discuss with the management of the health centers and ask them exactly what they need, what they plan to have, if they have energy, and yes, and if they want to have more AC, if they want to have telemedicine, like the case in Mauritania. So you have to discuss with them and really understand the need, not only what they have, not only the load that they have now, but the load that they will have in the future. So yeah, thank you.
Thank you so much for that answer. I wanted to ask a question to Paul. In your experience, how do you think government actors can be better supported to take ownership and be engaged in the long-term maintenance of health systems in fragile settings?
Yeah, I mean, this is a critical question, yeah, because in Sierra Leone, healthcare infrastructure is predominantly driven by international development. So the funding coming from government is very little to just take care of the operational cost of the Ministry of Health. The needs are, even though the health sector receives the highest from government spending. Also, structures are not within the Ministry of Health to take care of healthcare electrification. So this is a major problem, and the Ministry of Energy is constrained with dealing with the general energy access situation in the country. So what we are suggesting is that a unit be developed within the Ministry of Health, first to be able to develop good proposals, to coordinate international development support coming to the Ministry for Healthcare Electrification, but also to be strong enough to take over O&M and running costs, running CapEx after systems are deployed. So these conversations are going on. There is now a focal person for healthcare electrification within the ministry, but he's heavily overloaded and incapacitated, I would say, to deal with these issues as will be needed. So a lot of support is needed to have that unit anchored within the Ministry of Health, and we are still far from that. Kathy?
Thank you. And so I think we have time for maybe one more question. And we have one here. What can we say about the energy efficiency of medical equipment in these healthcare facilities that are being electrified? And how does that impact the electrification process and the sustainability of innovative financing models as they're applied in these settings?
Yeah, maybe just a very brief response to that from my end. Of course, what we have found in all the surveys that we have done is that energy efficiency is not really at the forefront of things that people think about. But certainly before we size a solar system, of course, we should always make sure that there's energy efficient appliances in place initially. And the highest saving probably that you can get is that if there are health facilities that have air conditioners that are utilized within the facilities that are currently run with diesel gensets, then it's certainly very much important to actually check that these air conditioners are indeed energy efficient. And also I saw one good comment on the chat box by somebody that mentioned that beyond using the RECs for the regular O&M payments, also facilities that are currently using diesel gensets can actually divert some of the funding that they currently have for using fuel for these gensets towards paying for O&M for solar systems. So yeah, maybe just I'll just respond briefly like this, and then happy to give to someone else.
I think we should jump to our conclusion because I want to leave a little bit of time for Shahab. Thank you everyone for your questions. If there are any last questions in the chat, speakers feel free, please, to answer those directly, and it would be great to keep the conversation going. Everyone should feel free to reach out via email to to discuss further. But now I'll hand over to Shahab Javeri, who leads our healthcare electrification work stream at the GPA. And he is just going to close us out by briefly sharing how we are planning to take this research forward, how we're planning to take this research forward. So Shahab, please.
Thank you, Katie. And thank you very much to all of our speakers for presenting all of your cases. Just a reminder about what Katie mentioned earlier, that this report contains 11 case studies. These are 3 that were represented today, but there are 8 more that have many more similar learnings, different learnings as well, based on the kind of projects that they were. And we encourage you to go through these and give us feedback on what more information is required in the sector that we should be collecting and sharing with all of y'all. This is one of the things that we will be taking forward at the GPA, sharing more information from the ground on what kind of projects have been working out, what kind of gaps are there, and we will try and enable some of those gaps to be filled in the best way that we can. One of the things that we're taking forward from here on is the pipeline that we already listed in our report. We are going to build that out, include more healthcare facilities, and strengthen the kind of data that we've included in the pipeline, and be able to consolidate a lot of the needs, aggregate health facilities across countries, and be able to take them to prospective donors, or just inform the sector more widely on the kind of investment needs in the humanitarian healthcare sector that are there. We hope that this area of work gets built out over time. And more importantly, in the future, we're able to collect more information around diesel, because even in the Energizing Healthcare Forum in Nairobi earlier this year, what was really prominent, what came out was that diesel expenditures are quite considerable even today for health facilities that have received solar power. Enough solar power, they might still end up using diesel, because that's just how fund flows work. That's because how behaviors are, and so on. And it's important that maybe this topic is better explored. We're able to understand, we're able to get more information on diesel expenditure, and be able to reutilize this towards renewable energy moving forward. So that's one of the work streams that we'll be working on a lot more. We're hoping to build out a more flexible long-term O&M fund that can support humanitarian healthcare facilities. That's in a preliminary stage. And lastly, we're also building out a portfolio on emergency healthcare needs and the energy needs within that. Very less has been publicly shared on the topic, although a lot of ready to deploy solutions are now available, especially since COVID. So on all these work streams, the GPA is open to information from all of y'all, whether it's health facilities that need solar power that you'd like to include in our aggregate pipeline, or whether it's ready to deploy solutions that your company provides or you've already procured in the past that you think are useful to others. We're open to all of this information so that we can share it with more people. Thank you so much, all of you all, for joining, and I'll stop there, Katie, if any last words. Thank you.
No, I think that you covered it all. I just want to say thank you again to all of our presenters for taking the time to share your expertise today. And thank you for our audience for the great questions and lively chat. And I hope that everyone has a lovely evening, afternoon, depending on what time zone you're in. Thanks, everyone.
Thanks, bye.